in the absence of, among second-line agents, which is preferred over others, let's discuss all of the second-line agents that are available for use. And I'd like to start with the thrombopoietin mimetics. So we were just talking about how thrombopoietin mimetics are not recombinant thrombopoietin. So can you discuss what are these drugs? And there are two that are FDA approved for use in America, romiplastim and eltrombopag. So how do they differ molecularly from each other?
So first of all, eltrombopag is a very tiny molecule, and it inserts itself.
Is that good?
Well, it depends on how you look at it, right? There are reasons why you wouldn't want a tiny molecule, and there are reasons why it's really good. It can be absorbed via the GI tract, which is great. Yeah. Whereas, and it inserts itself into the intramembrane portion of the TPO receptor. Romiplastim is actually a combined molecule of the FC portion of IgG and the piece that's actually fitting into the molecule, into the receptor. And the reason that was done was so that it would have a nice long half-life. And it can be given only once a week as opposed to daily with eltrombopag. And that binds exactly at the same spot on the outer portion of the membrane that TPO binds at.
And eltrombopag is oral, and romiplastim is
sub-Q.
A sub-Q injection, given weekly.
Given weekly. Because it's sub-Q, we know it's getting into the system. With eltrombopag, there's going to be some problems with food, with availability because of when a patient ate. I always worry if somebody has chronic diarrhea. There's a lot of GI disorders, autoimmune disorders that are associated with ITP, and then you have to worry, is this patient really getting it? And it's a matter of convenience for the patient. Some patients really prefer taking a once-a-day oral dose. Some patients tell me, I'd rather come in once a week and get the injection.
Right.
It's a little bit difficult because the original studies were done with self-injection once the patient was actually on a steady dose. Medicare has not allowed that, so most insurance companies have not allowed that. But there are some insurance companies that do allow self-injections, so it's kind of important to check because the patients after a while do want to self-inject.
Sure.
Especially if they're coming from far away.
Right. But I would imagine that is once there is a stable dose that achieves the goal platelet count, because often romiplastim has to be titrated based on the platelet count, so then you would want patients to still come in and get their CBC.
Right. But eventually, when I know what they're doing, I don't want to keep checking the platelet count. As I like to tell patients, I want you married to your spouse, not to your platelet count. Because they get very anxious about that platelet count, and it's so much better for them to just kind of, once I know they're safe, is to not think about it. The other problem is that the platelet counts tend to rock around a little bit. And so you don't want to be reacting to every single platelet count and titrating doses up and down. That's where I see patients getting into trouble with the drug. They have a lowish count 1 week, somebody increases a dose, they go too high, they hold it, they go too low. So it's really good to find a dose and just stick with it, and I usually just check my patients every couple of months and leave it at that unless there's some symptoms or something that make me say, you know, you better come in and get another count.